Restless leg syndrome. Restless leg syndrome, often known as RLS, is a disease characterized by an unpleasant sensation in the legs and sometimes the arms, accompanied with an urge to move that appears during periods of inactivity, is most noticeable in the evening, and is temporarily eased by movement. RLS is a widespread condition that affects 5 to 15% of individuals. Northern European nations have the greatest prevalence estimates, followed by Germanic countries, and finally Mediterranean countries. In the South and East, the predominance decreases. In numerous studies, females had greater rates of RLS than men. RLS may occur at any age, and most research demonstrate that the prevalence increases with age. Although investigations have shown a range of both central and peripheral nerve system abnormalities in RLS patients, the pathophysiologic cause of the illness remains unknown. Reduced central iron reserves are the most often implicated central nervous system change. In 40 to 60% of instances, there is a familial history of RLS. Despite the fact that no highly penetrant genes have been found, various genetic variations may enhance the risk of RLS. RLS genetics, like those of other prevalent illnesses, is complicated and likely involves the existence of numerous risk genes. Although most occurrences of RLS are considered primary or idiopathic, certain concomitant diseases, such as systemic low iron storage, uremia and neuropathy, spinal cord illness, and pregnancy, are often linked with RLS. More than 80% of RLS patients who undergo polysomnography have periodic limb movements of sleep or PLMS. They are not, however, particular to the condition. The frequency of PLMS in the general population rises with age and is estimated to affect up to 60% of older persons. Volitional motions such as foot tapping, akathisia, nocturnal leg cramps, positional discomfort, and leg pain from a variety of reasons are the most typical RLS mimics. Most of them may be separated from RLS based on the history and physical examination. RLS is a clinical diagnosis that should be considered in patients who complain of a strong need to move their legs when laying in bed or sitting, especially if the condition occurs mostly in the evenings. The diagnosis is determined based on the patient's history and does not need any extra testing, with the exception of an evaluation of iron storage in all patients and blood urea nitrogen and creatinine if uremia is suspected. Any drugs that may be causing or aggravating the condition should be identified. Therapy goals. RLS is a curable illness that usually responds well to medication. Therapy aims to minimize or eradicate RLS symptoms while also improving daily performance, sleep, and quality of life. Check iron stores. All RLS patients should have their iron storage checked. For individuals with iron deficiency or low normal ferritin levels such as serum ferritin level below 75 nanograms per milliliter, oral iron supplementation is recommended. Intravenous iron is typically indicated for patients with a malabsorption condition, complete intolerance to oral iron preparations, moderate to severe symptoms despite a trial of oral iron, or the need for a more rapid response due to the severity of symptoms. Any adult with severe iron deficiency, serum ferritin level as low as 30 nanograms per milliliter should be investigated for the underlying cause, which might be gastrointestinal blood loss, particularly in individuals over the age of 40 to 50, or a disease that interferes with iron absorption. Behavioral measures. Patients should be advised to avoid aggravated medications and substances like coffee. RLS is often helped by mental alerting activities, exercise, leg massage, and the use of heat. These interventions may be adequate for symptom alleviation in persons with moderate and intermittent symptoms. In most patients with chronic persistent RLS, we recommend starting with an alpha-2 delta calcium channel ligand, such as pregabalin, gabapentin, or gabapentin enacarbil, rather than a dopamine agonist as the first line of treatment. While both types of drugs are more efficacious than placebo, we prefer to begin with an alpha-2 delta calcium channel ligand to avoid the risk of augmentation and impulse control issues associated with dopamine agonists. A dopamine agonist, such as pramipexole, ropinirole, or rotigotine, is a reasonable first-line alternative in patients who are at high risk for side effects from an alpha-2 delta calcium channel ligand, such as those with obesity and its complications, a history of moderate or severe depression, disorders causing gait instability or respiratory failure, and a history of substance use disorder. If you find this video helpful, please hit the subscribe and bell buttons. And don't forget to like and share this video. Thanks.